These are my disclosures, nothing relevant to this talk. So we've heard a lot about different types of devices, and as you can probably see from the data that's been presented, a lot of these things work well, at least in terms of acute results with RV-LV ratio. But I'm going to take a few minutes and talk about the Indigo system, which is made by Penumbra. Really, the heart and soul of this device is the engine, which is, you can see pictured here. It basically is a device that creates a vacuum, a consistent vacuum, 29 inches of, negative 29 inches of mercury, and it's constantly on during the procedure. I'll show you the kind of the add-on feature that was mentioned earlier when we were talking about DVT, but it gives you basically a one-touch, you're on and you're off with continuous suction. The catheters themselves range from more of the arterial side of things with the CAT RX, which is a very low-profile system to do more arterial work, all the way up to the CAT 12 device. It's a very trackable, very forgiving tip device. Really, for all intents and purposes for venous intervention, we're talking about the larger catheters. And so the CAT 7 and CAT 12 devices are these laser-cut hypotubes that have a certain reasonable degree of torqueability. The inner lumen for the CAT 7 device is 082, whereas with CAT 12 it's 0131. And the ability with the CAT 12 device, which is what's primarily used in the treatment of pulmonary embolus these days, is that you have a couple different angled tips to kind of accentuate selective catheterization. Accompanying these is the separator, which we've seen used before in the DVT talk, and it's basically designed to unplug or facilitate clearing if anything gets stuck at the catheter tip. The entire line is approved for arterial and venous thrombus removal as well as treatment for PE. The add-on feature that was mentioned by Dr. Hahn earlier basically is what's called the Lightning Intelligent Aspiration System. It's kind of the, at least when it was brought out, was kind of the next generation. The criticism initially with this device was that it was kind of a constant bloodletting because it was a lot of manual flipping of the on and off switch. And so this add-on was basically engineered to provide some intermittent aspiration. And the way this is constructed is with the aspiration tubing, there are sensors, pressure sensors built in within the system, and then that's connected to the microprocessor, which is attached to the top of the device, and it automatically controls a valve that then alternates between continuous and intermittent aspiration depending on whether or not you're engaged in clot. And you get audio-visual clues. So you get a flashing green or yellow light, and then you get this kind of clicking, audible click that tells you whether or not you're engaged or whether or not, or whether you're in a patent vessel. And so the pressure difference is then registered by this microprocessor that then minimizes the flow. This is older data. I say old. It's not that old, but it's the study was done a few years ago, and the reason that I say it's old is because this device was study was published using the 8 French device, but it basically was the entry level data that was submitted by Penumbra to look at the device and its performance in symptomatic patients with acute submassive PE. You can see the indications for treatment there with BP, RV-LV dilatation, biomarkers that were elevated, and so on. And again, even with the 8 French device, you can see a significant reduction, 27% mean reduction in the RV-LV ratio, kind of the standard endpoint that people have used, different companies have used with regards to effectiveness, at least acutely. In addition, very low major adverse events rates at 48 hours. Hardly any of these patients received additional thrombolytics, so 98% of these patients did not have to have any additional intraprocedural thrombolytics. Very short device time, about 37 minutes, and 1 day in the ICU. But most recently, John Moriarty presented this data at the Per Consortium meeting in Tampa, looking at the Lightning 12 system. So this is now the CAT 12 device. This is the Strike PE data, and I'm going to talk a little bit about the interim analysis of the first 60 patients that were enrolled using, again, the Lightning aspiration system with the 12 French catheter. The study is designed for 600 subjects at 55 global sites. Again, post-market study, prospective study looking at follow-up at 48 hours and at discharge, as well as kind of midterm and longer-term follow-up with this data that I'm going to present on, again, on the first 60 patients. Inclusion criteria, again, acute PE, elevated RV-LV ratio of greater than 0.9 using the Indigo aspiration system. Patients were excluded if they had a very short life expectancy, if they could not get anticoagulated, or if they had metastatic cancer, or if they had a patient was already on ECMO due to hemodynamic instability. The endpoints in terms of performance, again, change in RV-LV ratio from baseline up to 48 hours post-procedure. The primary safety endpoint was composite of major adverse events. Again, these are frequently cited in multiple studies that you've seen presented earlier today. Major bleeding, perhaps one of the more significant things as we're looking at comparing these things down the road to anticoagulation, but also multiple device-related parameters as well. Secondary endpoints, we're looking at patient-reported quality of life outcomes, functional outcomes, device-related SAEs, and any cause mortality, and then, of course, if there's any symptomatic recurrence within 30 days. Point out a couple factors here on this chart with the results of the study, again, looking at the first 60 patients. Almost 20% of these patients had COVID-19. We've certainly seen a lot of thromboembolic events, both on the arterial and venous side. In the era of COVID, about a quarter of these patients had previous DVT and about 20% had a previous pulmonary embolus. Again, very short catheter time, just highlight the areas in red here. Short device time, 1 day in the ICU after the procedure, and just over a third of these patients did not even require an ICU stay. So if the goal of treatment is to keep out of the ICU and avoid thrombolytics, certainly meeting that goal so far in the interim analysis. In terms of major adverse events, you can see quite low. One patient had a major adverse event within 48 hours. That was an access site hematoma. There was one device-related SAE related to rupture of a pulmonary artery in a patient that was thought in retrospect to have CTEPH. So again, very low overall adverse event rate. This is the RV-LV ratio improvement. You can see by about 24%. Again, this is using the 12 French device. This is, of course, by CT angiography, and most people otherwise by use of an echo. Systolic pulmonary artery pressure, again, significant reduction overall of about 20% from baseline to post-aspiration. And then looking at the dyspnea at rest scale here from pre-procedurally at what's graded as a somewhat severe down to 0.5 at the time of discharge and out to 3 months, no significant dyspnea at rest. Improved 6-minute walking test. Again, these are all performance measures that are helpful in terms of patient-reported outcomes. I'll show you a quick case here. This is an 80-year-old female with chest pain, usual symptoms, progressive shortness of breath and dyspnea on exertion, a little bit hypotensive, a little bit tachycardia, a little bit tachypneic. O2 is about 94% on 4 liters. Elevated biomarkers and an ASPECI score of 2. You can see the RV-LV ratio here is abnormal, a fairly constrictive clot in the right lower lobe and at the level of the truncus. Initial pulmonary artery pressure is only 40. I would have thought that this would have been significantly higher, but it is mostly a unilateral thrombus, so I guess not altogether that surprising. After the first pass, you can see that there's been some improved flow down to the right lower lobe. After additional selective aspiration in the right lower lobe, you can see continued improvement to the distal branches of the right lower lobe pulmonary artery. This is the final run with the final PA pressure of about 28 millimeters of mercury. So a reduction of about 12 millimeters, which doesn't seem like all that much from an absolute standpoint, but gets you into a more reasonable range. And this is the final static image, remind you of what it looked like to begin with. What's new? Well, I cannot either confirm or deny, but word on the street is that they're talking about a larger device with perhaps an improved mechanism with regards to blood saving on top of the lightning intelligent aspiration. And then recently announced is the randomized controlled study looking at patients with intermediate high risk pulmonary embolus, comparing Indigo thrombectomy plus anticoagulation to anticoagulation alone. So in summary, the Indigo system is approved for both arterial and venous indications, including pulmonary embolus. The lightning intelligent aspiration system helps you reduce that overall blood loss related to the act of aspiration and creating a situation where you've got audio and visual clues to indicate whether or not you're engaged in clot. CAT-12 is the device primarily used in using pulmonary embolus as well as DVT. The older data that's been presented is from the 8 French catheter. It has shown successful acute relief of elevated right ventricular pressure with a low major adverse event rate, and perhaps most importantly, improved quality of life evaluation at 90 days. Again, you'll see the standard of care is changing. We got a lot of work left to do. A lot of these devices are quite successful in those short-term outcomes, but ultimately what we do long-term for these patients with potentially life-threatening thrombus remains to be seen. Thank you very much.